Good afternoon, everyone. My name is Maya Luria with TMC for Seniors, and I am thrilled to have Dr. David Teeple back here at TMC for Seniors. He is our TMC Stroke Director, and he's also with Center for Neurosciences. He's going to be talking about something that we always talk about during brain health. It's recognizing stroke symptoms, fast action. He's going to break down for you what those signs and symptoms are so that you know if you are ever encountering someone that may be having a stroke, what to look for. So welcome, Dr. Teeple. How are you today?
I am doing great. Thank you very much for having me. I'm always thrilled to talk about stroke and symptoms of stroke and how we can sort of identify stroke and get people treated faster, better, anytime. So thank you for having me. And should I
Yes,
just get going?
absolutely. So you have an online audience that's watching today. I'm going to put up your PowerPoint. And let's just also remind everyone that not only do we work on this together, you provide us a presentation, but we also work on Stroke Prevention Saturday, which is coming up on April 5th. And so, we can talk about that later, but that's something else that we do to assess your risk of a stroke. So I'll hand it over to you.
Awesome. I love it. And yes, a plug for Stroke Prevention Saturday. I think it's a super wonderful service that TMC offers, and I couldn't encourage people to go enough, but we'll talk about that later. So recognizing signs and symptoms of stroke. I'll back up. I get excited about stroke. I'm an excitable guy. So sometimes I talk a little fast. If I talk too fast and you want me to repeat something, please let me know. And with that, let's talk about our objectives. I'm going to talk about what exactly a stroke is. Okay, this is something that gets mixed up by healthcare providers and patients alike. And then talk a little bit about neuroanatomy to sort of help you understand then why we look for certain signs and symptoms of stroke. And then a little bit about what you do if you have stroke, if someone's having those signs and symptoms and what happens. So first of all, what the heck exactly is a stroke? So it's actually kind of interesting. If someone has a heart attack, it sort of makes sense, right? You're having, your heart hurts and you're having a heart attack. Why is a stroke called a stroke? And you ask most healthcare providers, they're gonna kind of shrug and say, I don't know. Why is it called a stroke? And it's interesting. Stroke comes from our terminology from the Middle Ages. And frankly, before that, people thought that if you were having a stroke, it was a stroke of the hand of God, that you had done something wrong, and this was your retribution for what you had done. And to this day, we refer to strokes as, instead of brain attacks, which would be much more appropriate, we call them as a stroke. We call them strokes, and it's a callback to that interesting history. But when we talk about strokes, to make it even more confusing, because the name doesn't really tell us what it is, we typically talk about three different things. Okay, one is an ischemic stroke. An ischemic stroke is far and away the most common type of stroke that we see, and this is where a blood clot travels up into an artery, blocks an artery, and part of the brain, okay, the part that's covered in yellow there, gets deprived of oxygen. And when that happens, does it hurt? No. Okay, you just lose function of that area. So that area encompasses my arm or my face. They can go droopy or they can go numb. If it's a vision area, I can lose vision. If it's a speech area, I can lose speech. But there's no pain associated with it. And this is a terrible thing to say out loud, but I think this all the time, so I'll say it out loud. I wish strokes hurt. Because if it hurts, people come to the ER. You come and something's wrong, I'm in pain, I need to go. When someone wakes up and they're like, oh, my arm doesn't work. I probably slept on it funny. I'm just going to go back to bed. And they wake up 8 hours later and like, my whole side doesn't work. We missed an opportunity to help that person. And so it's tough. So strokes don't hurt, loss of function. This is the most common type of stroke that we see, an ischemic stroke. The second type of stroke, the second most common type of stroke that we'll see is a hemorrhage, a brain hemorrhage. Okay, and sometimes we call these hemorrhagic strokes, intracerebral hemorrhages. All those things are the same form of what this is, which is an artery in the brain ruptures. Okay, and what you can see here is you have these big fat arteries that come into the brain, but you have these little things that come off these big arteries. These little arteries are what tend to be sensitive to high blood pressure, and they rupture. They can either clot off and block off and cause an ischemic stroke, or they can weaken and rupture. Thank you. And when they rupture, they bleed into the brain and cause deficits. Again, these don't hurt typically. They cause weakness, though, and they'll look just like an ischemic stroke, meaning you'll get weak or numb on one side. But these are very different in that rather than a clot there blocking blood flow, this is an artery that's broken and blood is extravasating into the brain itself. And yep, you can see right where that arrow is. That's where the bleed happens. And by the way, this example here, that's the most common spot that we see these types of hemorrhages occurring. The third type of stroke is maybe the most feared, but far and away the least common type of stroke, and that's a subarachnoid hemorrhage. And a subarachnoid hemorrhage is where an aneurysm ruptures around the outside of the brain. So an aneurysm is like this little bubble off of your blood vessel, okay? And that bubble then weakens. And when you have an aneurysm, do you have any symptoms? No. Aneurysms cause no symptoms by themselves, but when the aneurysm ruptures, this is actually the one type of stroke, far and away the least common type of stroke, and it basically manifests as sudden onset, worst headache of your life. And so if we look at strokes, 88% are ischemic strokes or blood clots. Oh, actually, I'll show you a slide on that in a minute. And only about 3% are this type. So strokes can cause headaches, these subarachnoid hemorrhages, but very rarely, 3% of the time. Interestingly, these are also the most dangerous type of stroke. The highest mortality is with subarachnoid hemorrhages. So the data, and albeit, this is the only data we have, and this is now several years old, but the data is roughly 800,000 strokes per year in the US. And if we look at it, about 88% are ischemic strokes, about 9 or 10% are hemorrhages in the brain, and only 3% are subarachnoid hemorrhages. So the vast majority are ischemic strokes, the blood clots that go in the brain, and those are the ones I spend really most of my time treating and worrying about and thinking about. So what are the signs and symptoms of stroke? Well, to understand that better, I think it's important to have some neuroanatomy or understanding of how the brain is set up. Plus, neuroanatomy is just really cool. So we're going to talk about it. So one, if we just look at the brain itself, it doesn't look that complicated, but if you see it in other ways, you get some sense as to how complicated and beautiful the brain is. And this is something called diffusion tensor imaging. And this is something that we're still developing, but this is a type of MRI where they can actually begin to see each of the different neuronal pathways in your brain. And you get a sense, right, of how incredibly complex, 100 billion brain cells, and then each of those brain cells and their dendrites and their connections going to different places in the brain make it a very, very complicated thing. And so with that in mind, we'll try to make it as uncomplicated as we can. So here is some random guy's head. If we remove the skull and the skin, this is what his brain would look like. Okay, so same direction. Okay, he's facing that way. The brain is facing that way. And we have the major lobes of the brain, the frontal lobe, right? The temporal lobe, parietal lobe, occipital lobe, cerebellum, and then the brainstem coming down. Eyeballs would be here. This is actually the olfactory nerve coming off, okay? And so the frontal lobe is, and interestingly, if you were to see, if I could bring a brain and show you guys, the frontal lobe in real life, this is how all the pictures are drawn. The frontal lobe really extends like back here. Your frontal lobe is enormous. And a big part of your frontal lobe is personality. I mean, it's what makes you sort of you in a lot of ways. And so, for instance, lobotomies that people used to do for people with psychiatric disease, by and large, a pretty awful procedure, right? If you destroy the frontal lobe, what happens? People become sort of what we term as abulic. They can just sit there and they don't care. You sit them in a room, and if you don't talk to them, they don't talk to you. They just sit there and they just don't interact with the world. They just don't care. And so the frontal lobe is sort of what makes you, the type A personality or whatever type of personality you have. It's your inner monologue, your conscience, your judgment, a lot of stuff that's hard to measure, to be quite honest. Interestingly, there's a type of dementia called a frontotemporal dementia. And frontotemporal dementia, what's different about that compared to other types of dementia, a preferentially affects the frontal lobes, and the first symptoms are changes in personality before anything else. And then muscle strength. So your primary muscle strength and motor cortex is in the very back of the frontal lobe. And we will talk more about that in a minute. And then you have your parietal lobe. So your parietal lobe, right behind the frontal lobe, is the sensory integration cortex. That's the part of your brain that really integrates all the sensorium that you get, especially light touch and stuff that you can touch, but taste, hearing even to some degree. And you have a primary sensory cortex right here. And if you knock this out, you'll make someone lose sensation in specific parts of their body. Occipital lobe, so that is your primary vision cortex. So when you see things wild, your vision comes into your eyeballs and then wraps all the way back around your brain to the back of your brain, which is where you actually integrate what you see into a vision. And then your cerebellum at the base of your brain is the part of your brain that's involved in coordination. We'll talk about that, but essentially, if I want to do something, grab something with my hand, the cerebellum is the part of my brain that coordinates all the different parts of different muscles that make that a smooth movement. And in people that have problems with their cerebellum, you ask them to do something and they can't do it very smoothly. They're kind of one muscle overcorrects and the other muscle overcorrects, and they don't have that smooth motor pattern. And that can affect their trunk, that can affect their legs. The first part of your brain that you knock out when you drink alcohol is the cerebellum. And so when people are staggering around like a drunk, that's the cerebellum isn't working right. And then lastly, your temporal lobe, which is the part of your brain that is most involved in memory. That's where your hippocampus is. The hippocampus is the first part of your brain that atrophies in Alzheimer's disease. And so short-term memory in particular. But also there are parts of language there. There are parts of hearing there. There does a few different things. Okay, so the homunculus. So this is a famous neurosurgeon that I've always been fascinated with by the name of Wilder Penfield. He was a neurosurgeon in the 50s and 60s, pioneered some huge, especially epilepsy brain surgery. He was one of the first people to wake people up in the operating room and test out their brain and see what it does. And so Penfield, and maybe this is my somewhat romanticized vision of him. He had a pen. He had this little electric pen, and would shock the brain in different spots and try to map out what the brain, what the function of the brain was. And this is a picture of him back in the operating room in the 60s and how things looked. And he was a rock star in the field of neurosurgery and neurology. And so this is a picture of one of his brains, and he would do things like this. So he would have he would map out areas and give them numbers, and then actually try to activate those parts of the brain with the person somewhat awake and see what would happen. And he defined this homunculus. Okay, and this is now I think there is some debate now about exactly what this homunculus looks like, but for our purposes, this is good enough. And that in all of us. So remember that frontal lobe, that motor cortex in the frontal lobe, and then the sensory cortex and the sensory in the parietal lobe right behind it. There's a map of your body there, and you can see in everybody. So if this is the brain, and it's like their eyeballs are here, and I've cut right through the middle of their head. In everybody in that sensory cortex, your feet hang over the side. So if there's a stroke over here, I can already tell you that guy's going to have a problem with his leg. He's not going to be able to move his leg because that's where the leg is. And then the hand and the face are always right next to each other. So when people tend to have problems with their hand, for instance, their hand is weak or numb, they almost always will have some type of face involvement because these are anatomically so close together. And so you can begin to see that there's this map, and I point out the huge amount of space that is devoted to function of your face and your hand. There is a ton of brain that is devoted to movement of your face and movement of your hand and sensation in those areas as well. And so that's something that we tend to focus on very much because it is very hard to get a problem with blood supply, for instance, that affects your leg but doesn't affect your hand and your face. And essentially, and so that's often questions that we ask a lot about when it comes to stroke. Now, it is important to recognize that the brain is split into two halves, right? The left brain and right brain. The left brain controls the right side of your body. The right brain controls the left side of your body. Okay, God did that to make us all confused. Job well done. And being a left-hander, I can't help but point out to you guys that the right side controls the brain of the left side of the body. That only left-handed people are in their right minds. Yes, groan. I suffered a lot in every desk made for a right-hander, and so I can say that joke. And so there is some notion, though, that the left side and the right side of the brains do different things. And, there are some people that would say, oh, the left side of the brain's the analytical, scientific part, and the right side's the artistic part, or vice versa. I would say that there is some truth to the right side tends to give you some better spatial understanding of things. And the left side, though, is really, really, really an important side of your brain. For all right-handers and most left-handers. And the reason is that's where language is. And language, comprehending speech, comprehending what you read, comprehending, getting words out, that's such an incredibly important part of what makes us us. And that's all located, generally speaking, on the left side of the brain. And so what we have here is, this is the language architecture. Okay, so eyeballs are up here in the front where Broca's area is. And so when you hear language, it comes in through the ears, into the brain, and through your temporal lobe, into this area at the top of the temporal lobe called Wernicke's area, named after a German neurologist, Karl Wernicke. And by the way, if you read things, when you read things, it comes over here too. This is the area where you comprehend what you're hearing or seeing. And then once you've comprehended it in this area, then it gets shuffled down something called the arcuate fasciculus into your frontal lobe up here. And this is Broca's area. And Broca's area is where you generate, okay, this is my response. I'm going to tell them what I think. And the words come out. And so when there's injury to Wernicke's area, you can't understand what people are saying or what you're reading. And when you have a damage to Broca's area, you can understand perfectly, but you can't get a doggone thing out. And so when that happens, that's called aphasia. And so this is a somewhat simplified version of language, and that's all involved on the left side of the brain. So interestingly, if you have a stroke on the left side in these areas, it's catastrophic. It has this huge impairment. But if it's the same area on the right side of the brain, you might not even know you have stroke. There might be some subtle personality changes or even nothing that you notice. And I've seen that happen. So the left side is much more valuable in general than the right side. Okay. Sure, fire away.
I was going to say, is that why most people are right-handed? Because they're muscle brain?
Probably. Interestingly, the skull in most people is thicker on the left side than the right side, and at least one of my professors used to postulate that evolved over evolution, so that when we got hit by a club on the left side, that we were less likely to die and have hemorrhages in our brain. I don't know. Okay, so then now that's your little quickie neuroanatomy lesson. So then let's apply that then to what are the signs and symptoms of stroke. And what we use as a general acronym that I think is very helpful is B.F.A.S.T. Okay, B.F.A.S.T covers really 90% of what we look for with stroke symptoms. I'll back up a little bit. Stroke is tricky. Okay, it doesn't hurt, and every one of us is a little different. And so B.F.A.S.T is the acronym that we use, but I am frequently envious of my cardiology colleagues, right? When someone has a heart attack, they have chest pain. You can get an EKG. You see abnormalities on the EKG. You can get some blood test called the troponin, and you see they've got a heart attack. We just don't have that equivalent in stroke. And is stroke the only thing that causes these symptoms? The answer is no. Can a migraine cause these symptoms? You bet. Can a brain tumor cause these symptoms? Can a seizure cause these symptoms? Other things can cause these symptoms that we look at stroke. And some of what we do is, we just have to do our, make our best educated guess as a physician treating a patient. But recognize this is what we use. It's not perfect, but there is no perfect thing, frustratingly. Okay, so now that I've confused you thoroughly, let's talk about F.A.S.T. So signs and symptoms of stroke. First one is balance, right? So the cerebellum, if the cerebellum gets hit, what happens is people feel off balance. Now they can get a sense of vertigo, which is a sense that the room is moving when you're not moving. It can be spinning, it can be moving, but that is a relatively uncommon symptom of a stroke. Most often vertigo is from the inner ear and not from a stroke, but every once in a while it can be. But more often what you get with cerebellar injury is ataxia. I can't walk. He's stumbling around like a drunk. He can't grab something when he's trying to grab it. Often it can be unilateral on one side, but I'd point out if it's unilateral in the trunk or unilateral in the leg, often people don't appreciate that one side's affected. They just know they can't walk, and they can't get their balance. So sudden onset, inability to walk normally, inability to control a limb. I had a patient once who had a stroke in the shower. And he's like, I was reaching for the soap and I just couldn't grab it. It wasn't working. Every time I told my arm to go, it wouldn't go. And so that can be what people have. Vision, sudden vision loss. So vision is a little tricky. So when there's a stroke of the occipital lobe, okay, then your vision gets affected typically in both eyes, and you lose vision on one side. So if you're looking, this is your eyeballs, and you're looking out, when you have a stroke, that happens, okay? It is tricky because most patients who have this happen to them, they don't know it. They don't recognize it. And now, just a chance for me to go off on a little bit of a tangent. The brain is a tricky thing, right? It is everything. It's us. It's our personality. It's our awareness, right? And when the organ in charge of knowing what the heck is going on is the organ that ain't working right, well, there's an inherent problem there. The reporter can't report what they don't quite understand is going on. And so it's interesting. I have patients all the time, and all the time's overstating it, but I have seen many patients over my years where they are blind. Half of the world is gone. They do not, what's wrong? I don't know. Something's not right. My wife keeps telling me I'm running into things, but I'm fine. And what I'll do every time I examine someone, look at my nose, which hand am I moving? And usually if they can see fine, they'll look at me like, are you crazy? Both hands, man. And when they can't, it's like, tell me when you see my hand moving, tell me when. And it's really when it gets in front of their nose, like, oh, there it is. And so it's a very interesting phenomenon. This is something that often spouses, children, friends notice about someone, that something's wrong. They're bumping into things. I don't know what's going on. It's like they can't see, but I don't know what's wrong. But the patient rarely complains they can't see. Now, the other thing that can happen, and is probably a little bit more common, is this. And so people can get sudden transient vision loss in one eye, okay? And it's painless. It might last for 30 seconds. It might last for a couple minutes, and then it goes away. And again, it's painless. They're like, oh, that's weird. And then they'll just go on and do their thing. That's an absolute get evaluated right away kind of issue. And the fear is usually that it's something in your carotid artery. And basically the artery that goes to your eyeball comes off your carotid artery. And so if you have a plaque there and a piece of that cholesterol plaque breaks free, very frequently it goes down up the carotid into the retinal artery and into the retina. And then what you get essentially is this curtain that comes down or goes up, and you lose vision. And again, it's painless, and then it goes away and you're fine. And so, so one of those things where people will tend to blow it off. Don't let them do that. That's a big deal. And usually, at the very least, it's the carotid arteries need to be checked out. Sometimes it's the heart, less commonly. And then every once in a while, it's a sign of an inflammatory disease in the arteries called giant cell arteritis. So always something that needs to be checked out. If you call your primary care doctor, you call your ophthalmologist, well, pretty much 100% tell you to go to the ER every time, which is the right thing to do. It's just the only way to get the studies done fast enough. Facial weakness. So why do we worry about the face? Remember that homunculus, right? Face and arm, huge amount of your brain that's involved in that. And so interestingly, with a stroke, so this guy, and this guy, can you guys see the difference between these two? And so this guy, and it is actually pretty subtle now that I look at it with my own camera. This guy's forehead is the same. He can't smile his left face, right? The right face is totally normal. The left face is droopy. His eyebrows, and I accept you can't see it very well, but trust me, his eyebrows look fine. His wrinkles are about the same. Whereas this guy, okay, now he's smiling great on this side, but he can't move this one. But now all of a sudden you see this eye is weak, okay, it's drooping on the bottom, and you see his forehead wrinkling on top, and it's not wrinkling over there. This guy has Bell's palsy. He doesn't have a stroke. And so interestingly, a stroke never affects your forehead. It always affects your basically below the eye, because interestingly, your forehead is innervated with both sides of your brain. It's the one area that's got innervation from both sides of your brain. So if you lose one side, you still have your ability to raise your eyebrows. And so I always like this, because whenever I see these patients, I know, okay, oh, you're fine. You're not having a stroke. This is Bell's palsy, and 80% of these patients get better, and even the 20% that don't get fully better get a lot better. Yeah, there's the forehead and the asymmetry there. And so this guy, he's got this asymmetric smile, but his forehead is nice and symmetric. So this guy I'm worried about. Okay, and then arm weakness. So typically, so then, when you're asking someone to evaluate, right? Smile. And what are you looking at when you ask someone to smile? Okay, you can count teeth if you want to. I mean, I'm looking at your dimples. This area right here. And you're looking at how nice that crease comes up. And on the side that's not coming up, you can see, right? He's got a nice, perfect dimple on this side, and then doesn't have that. That's what I look at more often than anything else. But you can also count teeth across if you're trying to figure out what you're looking at when you're looking at someone who's got an asymmetry. And then have them lift up their eyebrows. If their eyebrows don't lift, great. Still probably should go to the ER, but that's probably a Bell's palsy rather than a stroke. Arm weakness, we evaluate it, hands out. Now, typically what I'll do is I'll have someone put their palms up, like they're holding up a pizza box, is what I would say, and then close your eyes. And what you're looking for is when they close their eyes, subtle signs of weakness. The arm will start to pronate. Okay, this is supination. So they'll pronate over. Okay, sometimes the hand will sort of kind of come up and then turn over like this and then go down. That's weakness. Obviously, if they can't get their arm up or they're like barely getting it up, they're weak. But this is what we do. Close your eyes, and we're looking for this coming down. And again, we really care about the hand and the face, because that's by and large what the blood flow to your brain supplies. And this is a reminder, beating it into you guys, face and arm, huge amount of brain that's devoted to those things. Speech. And so then the two things that we look for then, you're looking for two things really, right? There's slurring of words, and like your mouth is, and slurring of the words, or dysarthria is the medical term, is essentially when it's like you can't coordinate your tongue and your palate, and it's like there are marbles in the mouth, and they just can't. They're saying the words, but they can't enunciate them clearly. Okay. I'm refused to make sounds like a dysarthric person, because I just sound like I'm weird when I do it. But it's, you can imagine when not being able to talk clearly and slurring the words, like a mouthful of food. And again, that's usually due to weakness or difficulty coordinating the movements in the mouth and the tongue and the palate. Speech is takes a lot of coordination of your vocal cords, of your tongue, of your throat, to be able to speak clearly. And that's different than aphasia, right? Dysarthria is weakness. Aphasia is really a dysfunction of the speech areas of the brain, right? And so that the Wernicke's area, that Broca's area. And so to assess that, often I ask things like, okay, and it can be tricky, because people who are aphasic, they'll tend to mime things. They'll tend to look for any clues about what they're supposed to do, because they know something's not right, and they're trying their best to to do something right. And so, doing things like asking them questions, stick out your tongue. Try not to stare at their mouth the whole time. But you're trying not to also mime. Show me 2 fingers, and you don't want to be like, show me 2 fingers, because that's miming. You want to ask them to do something that requires them to hear the words, comprehend what you're saying, and then have an output. Stick out your tongue. Close your eyes. Closing your eyes is always tricky because whenever I ask people to close their eyes, they blink. I'm like, is that a blink? Or do they close their eyes? I don't know. And so usually I'll do things like stick out your tongue, and aphasia can kind of run in lots of variations, right? People will often, there are some people that just can't understand anything and they just don't do anything. Some people understand a little bit, and you'll say stick out your tongue, and they'll open their mouth. They know it has something to do with their mouth, but they can't quite understand what you want. When they show me 2 fingers, sometimes they'll put up their hand and they're like, just 2 fingers. So they know at least that what part of the body I'm talking about, but they can't quite get the rest of it. Just as an aside, it's kind of interesting. There is a stroke syndrome called Gerstmann syndrome, where if you injure this area just above Wernicke's up here in the parietal lobe, people have very specific problems. They can't figure out left and right. They can't count. They suddenly just cannot count at all. And they can't figure out fingers. What's your ring finger? What's your index finger? They can't figure it out. Isn't that bizarre? It's called Gerstmann syndrome. It's a real thing. You see it. I mean, if you find someone with stroke there, they have those symptoms. Interestingly, if you were to have the same injury on the right side of the brain, in the parietal lobe, often people will get this profound neglect. And neglect is where they ignore half their body. And you can get people who they'll have alien hand syndrome. They don't believe their hand is theirs. And you can hold it up. Whose hand is this? I don't know. Well, I think it's your hand. No, here's my hand. Whose hand is this? I don't know. Not my hand. It's really fascinating. The brain is fascinating. So typically for impaired comprehension, they don't understand what's spoken. You ask them to do commands. Show me 2 fingers, stick out your tongue. It looks like confusion. Often when I get consulted for confusion, that's my first concern, is that, this is a stroke that we might have missed. And then back to Broca's area in the front there, that's your expressive area, right? The classic story is people say, I knew what I wanted to say, and just nothing would come out, or the wrong word would come out, or just complete gobbledygook. That's your Broca's area, or something near Broca's area that's not working right. So you can have them repeat a sentence for you. Is it clear? Do they understand what you asked them to do? Today is a sunny day. That's what I always ask them to say. But they used to teach us, can't teach an old dog new tricks. Ask them to do something simple. Can they follow a command? Can they name things? That's another subtle sign of injury to Broca's area. Can they name my ear? Can they name my earlobe? Can they name a pen? Sometimes those things are just shockingly difficult. Other things that people can have, sudden loss of sensation. That can happen. There's a type of stroke called the lacunar stroke in the area of the brain called the thalamus, a very common area to have damage in. And basically the cardinal symptom of that is just sudden loss of sensation on half of your body. People will describe it as it's either dead or sometimes it's tingly. And the key usually is that it's face, arm, and leg, and sudden onset. Lower extremity weakness, that can happen from stroke. It is definitely much less common, but frustratingly, the brain can do anything. And so the brain can do that. Often when people have lower extremity weakness, the first thing we think about are like lumbar spine or spinal stenosis. But strokes can do that. Sudden severe headache. So that is the sign, there's a cardinal sign of a subarachnoid hemorrhage. People who have bad migraine disorder, they know their migraines. And when it's something different, then that's something worth getting checked out. Usually for a subarachnoid hemorrhage, a CT scan is actually very sensitive for picking that up. But sometimes they do need a spinal tap to fully evaluate for subarachnoid hemorrhage. And then sudden confusion. There is an entity called transient global amnesia, which is kind of an interesting entity. Have any of you guys ever heard of that? Okay, so one of us. And so transient global amnesia is essentially this syndrome where people just suddenly become unable to make new memories. It happens suddenly, and they remember their name, they remember their spouse, they know things that they've known since childhood, but they can't make new memories for somewhere between 2 to 24 hours. And so it's the scariest thing. And so, people will be, classically, they'll repeat questions over and over again. Wait a minute. Why are we in the car? We're going to the hospital because you can't remember anything. Oh, yeah. Why are we in the car? And so that pattern of repeatedly asking the same questions over and over again, no focal weakness anywhere, no sensory loss, speech is fine. That's actually, when I see that, I'm like, oh, that's just transient global amnesia. You'll be fine. And usually we watch them, we get an MRI, but it's a benign event, not a sign of Alzheimer's disease. It's actually something that gets better. We don't really understand why it happens, usually precipitated by stressful events, but a little bit of a black hole still in neurology, but kind of interesting. So signs and symptoms to be aware of: B, fast, balance, eyes for vision loss, F for face, uneven smile, not so much the brows, arm weakness, speech impairment. We talked about both slurred speech or aphasia, and then time. Yes?
I'm sorry to interrupt, but Dr. Teeple, when did they add the B and the E? I learned long ago about FAST, F-A.S.T.
Yeah, I couldn't tell you when, and it's been on and off for years. We added it maybe 2 years ago here, and the problem is, right, FAST is great for a cortical stroke involving the carotids, for instance. But if you have a stroke that involves the back of the brain, which is a significant portion of strokes, a minimum of 20% of strokes, then you'll miss those. And so B-FAST is trying to capture those other areas of the brain that can cause strokes you don't want to miss. So 2-ish years ago, but it's been something that we've played around with for years. And we did it just to confuse you.
It's the two that I needed to know, that those were my.
I see.
Affected me.
I see.
I should have known.
I mean, I with no question that FAST is far and away more commonly put out there because it's just easier. And yeah, I think even now, if you go to like the American Heart and Stroke Association, you'll see FAST more frequently than you'll see B-FAST. But for that exact reason, I'm a big proponent of B-FAST. Yeah. Okay, guess what I wanted to stress on this slide? Okay. Time. Why is time important? So time is important because essentially once that blockage is there, you're losing brain cells. And this is an average. I would say that, interestingly, if every one of us in this room had the same blockage in our brains, we would all lose brain cells probably at a different rate. Some of us would lose them like that, and some of them it would take 24 hours to fully lose everything that you could lose. And so, but as a general rule, 2 million brain cells per minute, and all of that advances your brain age more than we want. So we know that time is of the essence. So trying to get people treated for stroke as fast as safely possible. Notice I said safely. That's what we want so badly. And so what are the treatments for stroke? The main medical treatment for stroke is clot buster, okay? And the drugs that we use as clot busting drugs are essentially something called tissue plasminogen activator. And now a lot of us are using a genetically modified version of that drug called tenecteplase. So we used to call it TPA because none of us want to say tissue plasminogen activator. So we say TPA, and tenecteplase we call TNK. So most of I think all the hospitals in Tucson are using TNK, and I think nationwide, as in general, most hospitals are using TNK. We think it ultimately a better drug than TPA was. And right now we use essentially a time window to treat stroke. That time window across the nation is about 4.5 hours. There may be some exceptions here and there, but 4.5 hours is generally the rule. And the fear is it's clot buster. The biggest fear with clot buster is brain hemorrhage. And so pushing the time longer and longer, what happens to the brain injury is the injury gets more and more severe, and the blood vessels in that part of the brain get leaky. And then when we push clot buster, the fear is that leakiness will turn into a big hemorrhage, and that's what we want to very much avoid. So that's why we tend to use that time window. And so if we give clot buster to 100 people, this is what you'll see, okay? about 32, 33 patients get better, okay? 13 of those, so about roughly half-ish, a little bit less, will get dramatically better, and the other half-ish will get just somewhat better. And then about 60 some odd % of patients, there's just no change. And then 3 patients can get worse, and worse can be really bad. Worse can be death. Okay, that's uncommon, but it can happen. And so we are very thoughtful about giving this drug. We don't just give it. We want to make sure, are the deficits that person's having worth it? And that's a tricky thing to answer, right? That depends on you as the patient. What do you feel about your deficits? Is this something you would be willing to live with? There's an element of, what do we think is going to happen over the next couple of hours? Is this something that we think is high likelihood to get worse? And then what are the other comorbidities that might make you at higher risk for bleeding? Things that make you high risk for bleeding: older age, bigger stroke symptoms, longer duration from when you were last known perfectly well. So all things that we're thinking about as your doctors when we're trying to treat you and do no harm. First, do no harm, right? Hippocratic oath, number 1. And it's an interesting it's an interesting thing. We are trying to do this as fast as we can and deliver a drug that has some serious risk, some risk to it, and do it as fast as we can. And so the question, of course, that I had once actually in this very room was, well, why not just give it in the ambulance? Time is of the essence. The sooner we give it, the better, no question. The sooner we can give the TPA or the TNK, the clot buster, the sooner we can give it to when the stroke started, the better the outcome. And so the faster we can give it, the better. And the problem is, we can't do it in the ambulance. We can't do it until we've had a CAT scan of your head. We need to know that there hasn't been a hemorrhage. Because this guy with the hemorrhage and this guy with the ischemic stroke, they may look exactly the same. And you give this guy blood clot buster, he dies. And this guy gets better. And so trying to do this as fast as we can. There are stroke vans. There are ambulances with CTs in them. But they're hard to do. They're great if you've got a compact city. But when you've got a spread out area like Tucson and all of southern Arizona, where do you put that stroke van that'll get to them fast? And do you really save much time by doing that? And on top of the fact of who's going to pay for the van and the cooling of a CT scan and the doctor on call to read that CT scan from the ambulance, or the clot buster that costs $12,000 that no one wants to pay for. There are so many logistical issues there that honestly, at least from my end, it's always been just get them to the hospital. It's faster than trying to deal with all that stuff. But this is the mobile stroke unit at UT Health in Houston. And that's one of my buddies there on the video, David, and that's the CAT scan. That's Dr. Grotto, who's one of the world famous stroke neurologists. And so this is in the scanner. And I can't remember now how much they said it cost. My buddies up at Barrow, they have one up in Phoenix. And it was some astronomical cost just to run the AC unit during the summertime to keep the thing cool enough to be able to run the scanner. So again, some big time logistical issues that have to get worked out to make that something that's really feasible in other places. One of the things that's been super duper cool has been the surgeries that we can do for stroke. And so I would back up and say that, from the dawn of stroke care, we've always wanted to be as cool as cardiologists, putting in stents and stuff in the cath lab. And what the problem has been is that it turns out that strokes are way more complicated than heart attacks, in the sense that they're caused by a huge variety of different things. A heart attack, by and large, is almost always the same process every single time. And in the brain, that's just not true. But we have found that there is a certain subset of strokes that we can do extremely effective surgery for. And this is large vessel occlusions. So this is someone's carotid artery, okay? And this is a big clot right there. And so when we see that, and we can see that on the scans that we do, we take these patients to the cath lab, put a catheter up into their brain, and essentially it's the most hilarious thing. It's a tube attached to a vacuum cleaner. And we just suck it out, and they'll suck out the whole clot. And then you repeat a scan, and the blood flow looks amazing. And I just saw a lady 2 days ago who had a stroke like that, would have been paralyzed or dead, and she was perfect. Walked out of my office like almost nothing had ever happened. In fact, if I saw her, I would have said, "You look like nothing ever happened," but she disagreed. But she looks amazing. And so this has been one of the neatest things that we've been able to do over the last, so 2015 is when this became FDA approved. And anytime that we can do it for a stroke, we are enthusiastically supportive. Frustratingly, not all strokes are large vessel occlusions. And so it's a subset of strokes that we can just make 20%, but 20% of some of the worst.
And you have to do it in 24 hours.
Yeah, by and large, 24 hours. That is the current guidelines. There may be a little bit of wiggle room there. And I think certainly all of us, especially for this procedure, where we're not giving you something that's purposely thinning your blood out and potentially causing you to hemorrhage, we're trying to move towards trying to identify how much brain injury there is and how much there is still left to save. And so there may be a little bit of wiggle room in the timing for that. But by and large, 24 hours, yes. And so this is one where you treat 100 people with Clotbuster, okay? And then on top of Clotbuster, if they're a candidate for thrombectomy, you do thrombectomy. This is how many more you help. And this is how many you hurt. And so this one is a slam dunk for extraordinarily effective. And again, I get excited about this because these are the worst of the worst strokes. And sometimes I see people walk out like nothing happened. And that's an uncommon thing 15 years ago. And I don't know if you guys saw this New York Times article. I can't remember. This was sometime last year, but they had this great article on this exact thing, the thrombectomy. And this is, I can't remember who this is at Columbia Presbyterian, that's where my alma mater, doing thrombectomy. And I would point out, that's Dave Jack. That's my man here at TMC doing that same procedure. And I've got Dr. Jack, Dr. Ashdown, Dr. Chug. I got a super stud team that is on call 24/7, ready and willing to do thrombectomy anytime. And so we love doing it. I guess this is my plug here for TMC. As a reminder, we're a comprehensive stroke center. We're the first comprehensive stroke center in Southern Arizona. I wish we did more ads where I got out there and stomped on it, but I couldn't be more proud of that. We have, we're partnered with Center for Neurosciences and TMC. We're joined at the hip, and then Radiology Limited, who does all of our NeuroRads reading and some of our thrombectomy care. And we have been Get With The Guidelines, which is American Heart and Stroke Association Gold Plus. Okay, super proud of this. From 17, 18, 19, 20, 21. Oh, and 23 and 24. I just haven't updated this slide. But I, as the stroke director, I mean, this isn't me. This is all the hard work of all the people at TMC. I could not be more proud. So. And then TMC is the spoke hospital. So, as the Comprehensive Stroke Center, we look to get, everyone from Southern Arizona the best care that we can. And that's Benson, that's Wilcox, Northern Cochise, that's the Copper Queen Hospital out in Douglas and in Bisbee, and then Mount Graham. I talk to these doctors all the time. I love being involved in the care of the patient in Southern Arizona. Super proud to be a resource for them and a place that they send their patients. And that's, I guess, all I'll say about that. And so to review, ischemic stroke. The vast majority of strokes that we see, about 88 to 90% of strokes, symptoms can be abbreviated in the acronym F.A.S.T. Remember, the time is super important. Okay, if you're having signs and symptoms of stroke, does it hurt? By and large, no. Do you ignore it? Heck no. Call 911. Our EMS are wonderfully trained to be able to assess you for stroke, and then they take you to the nearest stroke center, which is the right thing to do. Hopefully it's TMC, but my colleagues at St. Joe's or other places, I trust them too. Do not ignore the symptoms. Sorry, ladies, this means you have to yell at your husbands when they want to ignore their symptoms and tell them to come to the hospital. And the sooner we get treatment started, the better people do. Okay, when someone comes in and they're having an arm weakness, how do we know that arm weakness isn't going to turn into whole body weakness? How do we know that arm weakness isn't going to turn into inability to talk? And when we talk about strokes, I know you guys don't need necessarily hear this, but to say, we're trying to save life, but more importantly, prevent disability, right? That a terrible stroke takes away your enjoyment of life, and that's the biggest tragedy, I think, often. And so doing our best to prevent that from happening. So get to a stroke center, guys. And time is brain, and that's it. So I can open it up for questions for a couple of minutes.
Okay, I have some questions for you, actually.
Okay.
So, because we've had some questions come in. Is a TIA a stroke? Is the first question that I received.
And so a TIA is a warning for a stroke. So the best analogy I can give you would be, if someone has angina, right? Angina is chest pain without a heart attack. And that's a warning, though, that a heart attack may be impending. A TIA is like angina of the brain. And so essentially, it's where a blood clot, for instance, goes up, blocks an artery, part of the brain gets deprived of oxygen. You have the symptoms of a stroke, F.A.S.T, okay? But before there's any permanent damage, that blockage goes away. Blood flow is restored, symptoms go away. And so again, the way that I would look at that is that's a warning sign that you are at high risk for having an imminent stroke, and you need to be evaluated just as importantly as if you had a stroke. Okay, it's not a stroke, it's even more important. It's a stroke that we could prevent. And this is our chance to prevent it. And the faster you get that treatment, the better for you, the more effective we are at preventing the stroke.
Okay. Are there certain symptoms that people tend to ignore, for their stroke? I mean, I know you went through the F.A.S.T symptoms. Is there one symptom or two symptoms that people just tend to push off to the side that they should really be paying more attention to?
I don't know. I've seen them all. I guess the big one would be sudden painless vision loss in one eye. Sudden painless vision loss in one eye seems kind of nothing. And I could see that. I could see that same feeling like, I can move, I could talk, I could do everything. I just couldn't see out of my right eye for a minute, and then it was fine again. I think that's probably the big one that I would say. I can't tell you how many times I see patients come into the ER. I'm like, yeah, it happened a week ago. And I call, I waited, and then my wife yelled at me, and then I called my doctor, and my doctor's like, get into the ER right away. And so I would say, that's something, just come in and get evaluated. Every doctor is going to tell you the same thing.
Okay. And does a stroke increase your risk of a heart attack or vice versa?
Neither. And so they're caused by similar pathology, that, cholesterol plaques and narrowing of arteries in the brain cause strokes by and large, and the same thing happens in the coronary arteries. So when you have one, you're probably at higher risk of having another one. Meaning if you've had a stroke, you're probably at higher risk for having a heart attack. If you've had a heart attack, you're probably at higher risk for having a stroke. The fortunate thing there is the treatment for both generally tends to be the same thing. Blood pressure control, cholesterol control, diabetes control, heart healthy diet, don't smoke, regular exercise. And so those things, they cross over for both. If I had to pick one, I'd say in general, people who have heart attacks are at higher risk for stroke rather than vice versa. But, another question I get asked a lot, what ends up being most likely to kill my stroke patients? It's their heart. It's a heart attack. And so they go hand in hand. And certainly you want to be addressing both risk factors as aggressively as you can.
And you hear about AFib a lot with stroke too, correct?
Yeah, I'd say that again.
You hear a lot about AFib in stroke?
Absolutely. So AFib, if I look at stroke, about a quarter of strokes come from the heart, meaning a blood clot forms in the heart and then goes up to the brain. And the most common reason that would be AFib, atrial fibrillation. AFib is an irregular heart rhythm. Okay, it can come and go. If you're not in AFib at the time of your doctor's visit, you'll look fine. There won't be any sign of it. And so it can be a little bit of a tricky thing. I have had many patients who present with a stroke, and that's the first time we realized that they had AFib. People sometimes can feel palpitations or funny heartbeats. If you notice that, talk to your doctor about it. It's something that I wouldn't ignore. It may be AFib, it may not be, but get it checked out. But AFib is a big time risk for stroke. You can live a normal life with AFib. The way to prevent stroke from AFib is usually a powerful blood thinner, Eliquis, Xarelto, Pradaxa, Coumadin in the old days. And so people, as long as people are on one of those drugs with AFib, they can live a perfectly normal life, and it has a dramatic effect on reducing the risk of stroke.
My last question for you is just to clarify, what exactly does a comprehensive stroke center mean?
Sure. Okay, good point. You mean everyone here is a stroke neurologist and know exactly what I'm talking about? So a comprehensive stroke center means a hospital that has set aside specific resources to identify and treat all types of stroke. So, for instance, TMC has set aside resources with administrative personnel, stroke coordinator to run, to monitor the stroke care. That they've set aside resources to have 24/7 neurology and neurosurgery to be able to treat, to have the personnel there at 2 a.m, just as at 2 p.m, to be able to identify and treat a stroke. If they walk in, they get the same care as fast as they would at any other time. So it's a big resource allotment by a hospital and a healthcare system to be able to treat stroke effectively anytime and comprehensively. So not just neurology or neurosurgery, but to have the therapist there, the speech therapist, the occupational therapist, the physical therapist, the nursing care that's trained to be able to treat those patients, and then to be able to continue to monitor themselves and make sure they're applying the same good care to patients year after year after year after year.
Thank you. It's the highest level of certification, and so I just want people to understand that when you see that, it's a great thing. That's what you want. And so I appreciate you doing all of that and sharing all of that. Dr. Teeple, I'm gonna wrap up with our online audience. I want to thank you so much for being here. I'm going to turn it over to you for any questions that come in person. So thank you for being here today.
Yep, my pleasure.
Thanks again for joining us. We look forward to seeing you again. We've got a few more brain health classes coming up next week. Neuroplasticity Explained on Tuesday, March 25th at 3 p.m. And also a couple other classes next week. We've got Deep Vein Thrombosis and Aging, Understanding the Risks and Solutions on Wednesday, March 26th. And then our last brain health class is going to be the role of PT after stroke. And that will be on Thursday, March 27th at 10 a.m. So if you are interested in any of these classes, please give us a call. The phone number is 520-324-1960. I also want to go ahead and provide a little more information again, just in case you missed it earlier. We have Stroke Prevention Saturday coming up. That is going to be on Saturday, April 5th. That is over at TMC in the Marshall Conference Center. The phone number to register for a time slot is 520-324-1960. We will provide we provide some tests for you to be assessed of your risk of a stroke, and then you will get to speak with a physician afterwards. Again, the phone number is 520-324-1960. We look forward to seeing you again next week. Thanks.